Thanks. Thank you very much for the kind introduction, and thank you very much for having me. So yeah, we're changing slightly topic, but I'm going to be talking about focused ultrasound and how it can be used to change brain activity in a transient and safe way, and how potentially that could be interesting if we're thinking about certain dysfunction in certain circuits of the brain. Right. So, as I'm sure all of you know, ultrasound is extremely prevalent in care, and it all depends. I mean, the way ultrasound is used depends on the intensity, really, that is used. So, at very low intensity, we're all maybe remembering amazing memories of seeing our babies before they're born. So, this is in the case of diagnosis imaging, where ultrasound really those sound waves that are so high we can't hear them passes the tissue and they're just read out. So there's no interaction in the tissue except taking pictures. Now at very high intensity, and this is what Tom is going to talk about after, we can focus the beam wave into the tissue and we apply so much energy that the energy is going to change permanently the tissue it's interacting with. And the principle is exactly the same as sunbeam that could be focused in a particular area and increase the energy so much into this area that it could burn the tissue. So we're talking about ablation here, or referred to as non-invasive surgery, which is incredible if we're thinking about, you know, getting deep in the brain without having to drill into or to cut through the skull. But what I'm going to be talking about today is not HIFU, it's in the low-intensity domain. And again, in the low-intensity domain, there's different ways of using focused ultrasound. One is to do neuromodulation. The other one is to actually use it in conjunction with micro-agent, microbubbles that are injected into the bloodstream. And those microbubbles are going to oscillate, and they're going to, for example, open the blood-brain barrier in order to put some certain drugs in certain areas of the brain. And this is not what I'm going to talk about today. I'm going to really focus only on focused ultrasound for transient and safe interaction with the brain. Right, so just as a little intro, because maybe some of you might not be familiar with it, it's quite an early neurotechnology, even though ultrasound neuromodulation had been found since a very, very long time. I'll explain that in a minute. So advantage, well, you don't have to cut through the skull, you don't have to put an electrodes, for example, in deep parts, but you can be extremely specific when it comes to spatial resolution, and you can go as deep as one wish to go, and this is all down to the hardware that you're working with. So in theory, you could go as deep as the midbrain, and you can have a resolution about a few millimeter, if not lower, depending on your fundamental frequency. And I have done this many, many times on myself. I am also a big user of TMS, and I can tell you that it's really nice and comfortable. You don't have any muscle twitch. And so it's usually very well accepted. And I guess there is also something quite interesting about ultrasound is that it is so much already in our care system that it's actually really, really well received as a way to, you know, be putting yourself onto a technology. Ultrasound has this nice representation in people's experience and mind. Okay, and before I go on to the challenge, if you are like me and you're interested in interacting with the brain, at this moment you might like, whoa, this is a revelation. And I think I am like that. I think it's fantastic what we can do with ultrasound. It might actually be a revolution in the way we're being able to understand the brain and the way we can treat it. But there are challenges, and those challenges come down to a few things that are hard to fully characterize in the physical sense. And the first one is this beast here, which is our skull. So the skull is problematic because most of the acoustic energy is going to be lost at the skull interface in some ways. And I'm not going to bore you with all the details, but there is so many different acoustic loss that are happening at the skull interface. Refraction, which is due to the speed of sound, absorption, attenuation, you name it. There's so many issues here. And if it was easy to characterize, we would have no issue. And if there was no variability across individuals, we would have no issue. But there is a huge variability across individuals. From time to time, you go, depending on the person you're interacting with, it could go from 60% loss to 99% loss. Point where you wonder if it's even worth it to invite people for treatment. So, and that comes back to what I was trying to say at the very beginning, is that ultrasound neuromodulation had been found quite early on, actually, by the Fry brothers. And this was a study in a cat where they were looking at VEP, so these are evoked potential due to flashing lights. And when they were putting the ultrasound on, they could see this reduction in VEP. But they didn't really know how to deal with the skull, so they just removed it. So it's not exactly how we want to treat our participants. So the way we do it classically now is that we invite people for a pre-treatment phase, where we're going to put them in a scanner, an MR scanner or a CT scan if the patient population is such that you can argue that exposing them to radiation is okay, but usually we don't want that. So we put them in a scanner, an MR scanner, and we extract information. We extract a T1 for neuronavigation, we extract skull, and from those images, we're going to have to then map onto acoustic property of the tissue, speed of sound, attenuation, absorption, and we're going to have to simulate transmission. That's very important if we want to think about dosing, because I need to know if your skull is transmissive or if your skull is transmissive before you come in. So this is something that I spent quite a lot of time thinking about when I started. It maybe was destiny, but when I opened my lab to start in humans, because I was working in non-human primate before, COVID happened, and I had nothing else to do than thinking about these issues. And I think it was very important. So my postdoc and I, we put together an open source that allows you to go from a T1 image to acoustic property. There are other tools that exist now, so if you are interested in this field, it's a lower cost to start now because there's a lot of tools available. There is even commercial tools available for you. If you just wanted to actually not have to do it, you could just feed the program the skull image, and it will do the acoustic and the thermal simulation for you. So there are ways to deal with this and to optimize your treatment. Now, there's another thing that is a bit benign, but it's important, and it's been an issue in the field because some people were not fully aware of it. Is because if you haven't really put the transducer on your head, you don't realize that there is a sound you're going to hear. And it's a bit counterintuitive because we don't hear the fundamental frequency of ultrasound, it's too fast. But we hear the envelope of the tissue, of the envelope of the waveform, sorry. So for example, if you had a 5 hertz pulse repetition frequency here, you would hear something like this. It's not nasty, but you have to account for it, and it's bone conducted. So the person that's actually doing the experiment is gonna hear nothing, but the person that is receiving the ultrasound is gonna hear it. And that's only important if you're thinking about a sham, a proper sham where you're controlling for those peripheral sensation and the auditory, because that's gonna cue the participants. A lot of things happen when they know that the treatment is ongoing. So we need to think about this. Another problem is that you have bubbles. And it's the same thing for imaging, by the way, but in a way it's a little bit easier to deal with a skin that doesn't have hair. So when you have two impedances of different tissue at the boundary between the two tissue, you have reflection. This is a function of the differences in impedance. Boring detail, but in fact, if you go through air bubble, you have 99.9% reflection to your transducer. That's very problematic. So my lab looks a bit like a hair salon where I spend a bunch of time doing hair. And it's a bit of a joke, but it's very important to prep participants really thoroughly, very carefully. All right, so advantage, but also disadvantage. Now, let's be theoretical about the fact that we can now interface with the brain with high precision and everywhere we want. And that's amazing. But we have another problem, is that we have still a limited understanding of how to map symptom to circuits. So my field prior to ultrasound neuromodulation is called computational neuroscience. And what I usually do is I have people come in the lab, I put them in the scanner and they perform tasks, gamified tasks. And I have assumptions that there is an underlying circuits, and this underlying circuits has different mechanisms throughout, like different nodes maybe are underlying certain processes, and maybe the interactions between is important. But we don't really know that, so we need to infer it. And the way we do it is we have models of the circuit, and we perturb the circuits. And now we have this amazing tool that allows us to do it. We can actually probe the different nodes. We can probe those mechanistic questions. Ultrasound is so incredibly volatile, that, versatile, that you can actually stimulate at the exact same time 2 different nodes if you wanted to disrupt, the communication between 2 nodes. You could stimulate along a track. This is called holographic ultrasound stimulation, so you could just plan to have multiple sonication along a track. It's really infinite what you can do. We also have started to look at subdivision of the amygdala and of the nucleus accumbens, so you can really be precise there. And I think that's really exciting because all of a sudden we can ask good questions, which I think if they are answered could lead towards better clinical translation. So it's really my view that if we have to open the black box a little bit more mechanistically, if we want to understand the brain and if we want to have proper prediction over clinical outcome. All right, so now I'm going to give you an example of a study that I ran a few years ago now, and I was interested in a part of the brain that's fairly well known that has to do with reinforcement learning, with learning. So learning happens where you have a repetition between certain cues and events in the world. And if you are looking at this long enough, at the very beginning, you're going to have those dopaminergic surges that are happening at time of outcome, and they transfer after a lot of repetition to time of the cue. This is extremely well known. It's all those dopaminergic projection onto the nucleus accumbens, and it's called reward prediction error signaling reinforcement learning framework. So we know about this, and this is actually why after learning, when you see the cue, you already have those anticipation signal that's going to drive the organisms towards selecting that cue, for example. So what I was saying is one of the first, main hub of these circuits is the nucleus accumbens. And that's why it's so important in addiction, but other forms of compulsivity/impulsivity disorders. So the question we started with was, can we target the nucleus accumbens with TUS, with transcranial ultrasound stimulation, and impact reward-related function? And I'm going to show you how it is a really robust signal, this reward prediction error. And then I'm going to show you how an ultrasound field look on top of it. So this is an MNI brain. The eyes of the person would be here. This is a sagittal plan, and you can see the medial wall there. And this is the anatomy of the nucleus accumbens. So the more purplish, the more likely you are in the nucleus accumbens. And this is my reward prediction error signal. It's only 4 participants, a very strong signal. And so the hypothesis was, let's try to disrupt this signal, or at least change it, perturb the activity in this region. And this is how my acoustic field looks like by positioning the transducer over here, and it's like going through the internal capsule. So that's what you would do if you're doing deep brain stimulation. Okay, so we have a task that we believe will activate the nucleus accumbens, almost certainly, and we have the ability to interface with this brain region and perturb the activity. And you can do it bilaterally, of course. I was just showing one part. So the protocol we used is prior to putting people in the scanner. So what I'm after are neuroplastic effect, and we have a lot of experience in the past to prove that this was true, that you can induce neuroplasticity in the brain. We had done studies with GABA, and we found a change in GABA for about 2 hours post-stimulation. So we pretty much were certain that we would get an effect in this window. So we had a 5 Hz PRF prior to putting people in the scanner, and when they were in the scanner, they performed this probabilistic learning task, and they had to learn which cues was more likely to give them a reward. And we decided to have our active site of interest, but we also had an active control. So this is the nucleus accumbens, and we also stimulated the DACC so that we could really talk and argue about specificity here. And we also had a sham, which was bone conductive through a headphone sound that mimicked the ultrasound stimulation. So briefly, I'm going to show you the results. So one thing you can easily look at is a switch states type of behavior. So if you've been rewarded, you're more likely to stay. This is just how animals, pigeon, monkeys, us do in those tasks. So you can just simply look at the strength of relationship between stay and have you been rewarded before. So that's what I'm going to plot here. And of course, that's the case. You're more likely to stay if you've been rewarded. And this was the same after stimulation of the DACC. We couldn't find any difference. But we found a big difference after sonicating the nucleus accumbens. And we could also check when they were in the scanner, when this effect, this differential effect was the strongest, and it was around like 40 minutes post-stimulation. I can plot the same for the other region, and there's no difference, which really proves specificity. And this is the learning curve. So they basically became better at the task. So I remember after publishing this paper, some journalists calling me and saying, "Oh, have we found, a way of augmenting their cognition?" Because augmented cognition is very buzzy at the moment. And actually, I'm quite glad that this task showed that this is not necessarily the case. So they also started to do mistake in this task. So in the task, you have 3 symbols. Only one is good. The other ones are bad symbols in the sense that they gave you those low probability reward from time to time, but most of the time you're not going to get a reward. But from time to time, you're going to get those noisy reward. And noisy reward should be ignored. And in this task, after nucleus accumbens stimulation, they started to repeat those things, which is a little bit of a mark of myopic behavior, which is almost like a bit, they become impulsive, basically. So they were better at the task, but they also became a bit impulsive, which I thought was really, really interesting. In terms of bold changes, if we just look at the reward prediction error representation and we do the differential, we could find an enhancement of the bold signal in the nucleus accumbens, which was right where we sonicated. This was not where the case for the control region. And we also found a change following DACC for other types of processes. And it was quite interesting because it was quite a nicely distributed effect in the cingulate. Okay, and then we went one step further, and this is because we had the chance to work with a neurosurgeon that had patient with DBS. So this is real electrodes that are constantly stimulating the nucleus accumbens, right? So we could just change if the same indices of the learning task had been changed, and it was the case. So for us, it was almost like an indirect way of confirming target engagement, which was, again, extremely exciting. So we've done more studies in, if you're interested, I'm happy to share many others. I'm only going to present this one today. So the clinical direction that we're going after, so I'm interested in a lot of things that have to do with action and compulsion and repetition, perseverance. So we've started a work on looking at OCD, but obviously following the nucleus accumbens stimulation, now we've been moving on to alcohol use disorder. And I can share a little bit on this because there's something quite interesting that starts to emerge, and please take this with a grain of salt because it's only n equals 7, but we've changed the PRF, and this was something that I was very interested in because there was a lot of animal literature that was saying, well, you need to be stimulated at 5 hertz to have a certain type of response of the tissue, but if you go higher pulse repetition frequency, I'm sorry you can't see it, but this is 5 hertz and this is 40 hertz. You can see that the effects are quite different, so I think it's quite interesting, but it's just a beginning. And just a word on safety, we have performed low-intensity ultrasound neuromodulation in more than 400 sessions now, about 175 participants and healthy and patients of different forms. And I'm very pleased to say that beyond and above sham, there is no side effects that are significant. Now, one problem with the study that we conduct in my lab is that we put people in the scanner. We put people in the scanner right after they have been stimulated, so there's no way for us to disentangle really the scanner problem. And they report that they get sleepy, that they get a bit numb, and so on, which is what they would report in sham. So for us, what was important really was the difference between the two. And that will be it for me. I'd like to thank my lab, my collaborators, and thank you again for the committee for inviting me. And I'm very pleased to take a few questions. Thanks.
That was great, thank you. So do we have some questions? One at the back over there. Yep, you.
Hi, thank you very much indeed. One of the questions that often comes out here is the duration of the effects that you're experiencing. So I was wondering how you deal with that, especially when you're approaching clinical conditions like OCD, whether you're able to induce effects that last longer than a few seconds or minutes. Thanks.
Sure. So, I mean, the effect that I'm reporting here are classically around 1-2 hours or more. But obviously, the question to long-term effect is the one that we all have in mind. So, is it the case that you would have to repeat the sonication multiple times across a few weeks? I think that's some strategy that have been taken in TMS. But I want to challenge our opinions on that, really, because there are things that we have observed that are a bit strange. So I'm a firm believer in data, right? So I put people in a scanner and I observe data change in neural signal. And I can say, well, after 2 hours, things are going back to baseline. The thing is with psychiatric conditions, and I've seen this, is that when the person is experiencing a new state, a state that is so new that it makes them almost a bit shocked, that has a much more prolonged effect. So that's why almost I feel like an attractive state problem, right? Where you have a really chaotic problem that is all of a sudden shift, and that has a longer term effect than the pure neuroplastic effect of the ultrasound. So we have observed that in non-human primates that you would have, neuroplastic effects that were a few days, but never more. And what we observed, for example, in the OCD study is that effects are much more long-lasting than 1 week, 2 weeks. And they are still, responding differentially to those severity of symptom questionnaire and other, yeah.
Alan.
I really enjoyed the talk, and also your enthusiasm for the technique was great, but can I ask what's a desperately stupid question?
Of course.
What do you actually mean in this context by neuroplasticity? Because I tend to think of it as sort of dendritic growth or connection or reduction, but I'm not sure that's what you're meaning, or is that what you're meaning?
It is what I'm meaning. So, I mean, by neuroplasticity, I'm meaning long-term potentiation, things that have to do with the cascade of effects going at the synaptic and even the intrinsic synaptic response of the neuron. But what I've been discussing before in the talk is what is really clear with ultrasound compared to other forms of more, let's say the more direct way to interact with the brain is through currents, right? This is mechanical pressure waves. So it's going to interact with mechanical sensitive ion channel, and mechanical sensitive ion channels are very present in the glia. So what we have observed in small animal is neurogenesis. So neurogenesis does happen after even a short amount of ultrasound, which is extremely fascinating if you tell me. And I think it's because traditionally we're just being obsessed with neurons. But there's so much more. Neuroplasticity is not just neuronal, change.
Over there.
Thank you. It's very exciting to hear the potential for focused ultrasound. I just wondered if there are 2 bits to my question, if that's okay. Can you modulate the effects, i.e. remove them by changing pharmacology or anything? And secondly, do you notice any particular changes in different networks that you would see in resting state afterwards?
Yes and yes. So there's a lot of ongoing work into that baseline, that could be changed through pharmacological drugs and maybe allow the neurons to be even more responsive or less to those changes in pressure and displacement. Your second question is even more crucial, I think, is that we really see a lot of differential activity depending on the cell type and depending on the state of the tissue. And what I mean by state is whether or not the tissue is active. So if you have, you can think about a specific circuit and whether it's actually been already engaged into a process. If you're putting ultrasound on this, it will be differential than if it's at rest. So it means really that there is an interaction problem. When we're thinking about the direction of an effect, I like to think about it as a three-way interaction. It's the cell type matters, the protocol matters, obviously, and then there is the state. So it's not completely unsolvable, but it's complex.
No, I was thinking about the larger different networks, and if you were asking a particular task to be, you were looking at trying to modify performance in a particular task, whether you were getting specificity among networks with that. So rather the DFM or one of the others.
We've been trying to stimulate multiple regions depending on the cognitive process that we think we're interacting with. If that's the question, maybe I'm not fully understanding the question.
Thank
We
you.
can discuss this after, sorry.